Good morning. This is Professor Swindell. We'll be talking about leadership and management. This is for Nursing 111, Role Development of the Practical Nurse. This information comes from chapters 1 and 2 from the ATI Leadership book and other resources, as you'll see throughout the chapter, throughout the podcast. These are strategies that you'll use for your entire practice. So it's something that although we say some people are born good leaders, it's strategies that you need to develop. So let's begin. This poster about leadership says the leader always sets the trail for others to follow. And we'll talk about some characteristics of leaders and good leaders compared to management. Leadership versus management. So sometimes you see that leadership and management, those words are used interchangeably, but they really do have different meanings. So leadership generally is considered broader and more futuristic versus management is more of a local function and is more task focused. A leadership may have inspiration and management is more day-to-day perspiration. Ideally, leadership and management complement each other and build on each other. There are some people that are good leaders, but not good managers, and some good managers are not good leaders. And some people have the role of leader, but they're not in a more formal role as a manager would. So some of the characteristics that both leaders and managers have in common is the ability to set realistic goals, to try out new ideas, new things, and think positively. Keeping the people they work with and for positive is a great strategy. So this slide shows all the things that go into a leader: energy and action and goals, skills and knowledge, self-awareness, communication ability, and they're all interacting as skills of a leader. Let's talk about some different types of leaders. You probably have heard of authoritative. Sometimes we'll describe it as autocratic. Also known as. Democratic is another type of leader, as is laissez-faire. Some leaders are a combination of all, and they're situational, that there's times that we need to be more authoritative or more democratic or more laissez-faire. So you see some references will have a fourth category of multicratic or situational leader. Let's talk about authoritative. Authoritative leaders are directive, bureaucratic. They achieve goals by setting objectives and then have other people do the work. Not necessary for input from other people. And they believe that they have complete authority and should not be questioned, and don't encourage individual initiative. More task-oriented, making decisions independently and issuing orders. Do this, do that, get that done. This type of leadership does not work well in many situations. But during an emergency, somebody needs to be in control and somebody needs to take charge, and that is often an authoritative leader has those characteristics to do that well. Democratic leaders are are focused on the abilities of each member of the group. They understand what the different characteristics of everybody in the group are. They encourage people to participate in problem solving and will use group consensus, an agreement amongst the group to make a decision. People that are led by democratic leaders are informed of the goals of the organization, and there's a direct relationship to attaining goals, input from the people in the group. Instead of power struggles, I'm the boss, you're not the boss, democratic leaders will often turn the problem over to the group. What do you think? You address it. And will often lead by suggestion rather than domination, as you'll see in an autocratic leader. Persuasion and teaching rather than rule with an iron fist. Group members generally report feeling more satisfied because they are participants in the decision-making processes. There's good open communication, usually have good output of work product because people are collaborating and cooperating, and you could say morale is higher. In laissez-faire leaders, you see they're the complete opposite of autocratic leaders in that there's little direction or little directions coming down from the leader. Individuals can do whatever they choose with little direction or no direction from administration. There's a laissez-faire leader doesn't do much planning. Communication exists between up and down the chain of command and between group members, but people can lose focus, can lose morale because they're not always sure what they want to do, and there's no necessarily incentive. You might see work output low unless there's somebody else that kind of steps in and becomes a more informal leader. And you might see in a professional group of employees that this type of leadership works, because everybody knows what they need to do. They're highly motivated and focused, so they don't need much input from a leader. So the group, it depends. Characteristics of leaders generally will create a vision that is inspiring to others, will show others the way, and guide others. It will clarify values and sort of develop a mission statement. How are we going forward? What is our vision? Where are we headed? Leaders often can be formal, meaning they have a title, but they often can be informal. Somebody just shines through. Usually in classrooms you find informal leaders. Sometimes their peers recognize them and they become student representatives. That's an example. You might have somebody that everybody always goes to for advice. They're the informal leader. They might not be the unit manager, they might not be the charge nurse, but they may be somebody else that has leadership characteristics. They inspire people to do the right thing, have a vision, and are also good problem solvers and have critical thinking skills. They're positive energy, positive attitude. They communicate well, are respectful towards others. Those are all important characteristics of leaders. So different types of leadership. One, transformational leadership, where you see that in a group that's cohesive, that you have a common vision amongst the people in the group, and that at different times somebody might be a leader because they're stronger in that. So they're going to take charge now. So It depends upon the skills and qualities of the members. Remember, not um, all group members in this case are both leaders and followers. And in semester 3, and in parts of semester 2, you have the opportunity to be evaluated by your peers as both a leader and a follower. Some people don't like being followers, and some people don't like being leaders, but you get constructive criticism both from your peers and your instructors on how you do. So you are going to be assigned to give assignments and collect data from your peers as the leader. Sometimes you might have an opportunity as a third semester student to work with second semester students, so that's helpful as well. So these are people that you don't know as well as your direct peers. So with transformational leadership, you may not see like formal job titles per se. But because everybody has this collective common vision, the group can identify what the best thing to do is, and it works well because everybody's involved in the decision-making process. Versus this view versus transactional leaders. So in transactional leaders, the focus is on an immediate problem. It's maintaining the status quo, don't upset the apple cart, and uses rewards to motivate followers. A good concept to talk about in leadership management is the concept of emotional intelligence. And this is simply the ability to perceive and manage the emotions of yourself as well as of others. Can you perceive where people are coming from? So just like we've discussed a couple of times already, as a nurse, you need to understand where you're coming from so that you can provide the best care to others. So understanding what emotional intelligence is, understanding what that concept is the beginning. It's practicing the skills that is a little bit harder at times. Somebody that has emotional intelligence, one, understands the perspectives of others, is open to constructive criticism and new ideas. Somebody that's maybe less emotionally intelligent at the time may take that very personally and be defensive. Emotion should be channeled in a positive direction, and this is an important one, is refraining from judgment, not jumping to conclusions until all the facts are in place. A person with emotional intelligence is committed to providing quality care. So that's some leadership kind of qualities and characteristics. Let's talk about management. So the functions of management is the planning, the what are we going to do, who's going to do it, how are we going to do it, organizing, the chain of command or the hierarchy, where in what line of the hierarchy are decisions being made. Management's involved in staffing, so making sure that there's enough staff is a role of management. Directing includes the motivating of staff to perform their assigned tasks. Would be management functioning, and controlling. This is the piece where a manager is responsible for evaluating how the staff they manage are performing, and how are we doing towards the goals we've established, to make sure that we do what we're saying. We do what we're saying we're going to be doing. So let's see the next slide is talking about characteristics of managers. So A manager is usually somebody that's appointed, the unit manager, nurse manager. They were interviewed and they, got the job. So they are a formal position. Who do you go to? Go to the nurse manager. So they're assigned or appointed. They focus on the organizations, the units, their core responsibilities, day-to-day work. How are things going? They will, in the case of nursing, have clinical experience. Their job includes coaching others, bringing people along, mentoring others. More administratively, they have the budgeting, the hiring, the firing, the meetings, all of those. 10 meetings a day. You'll see managers running around going to. Some managers will have leadership skills because you see that vision piece and the coaching of others and the defining the vision and mission of the group. But not all leaders have managerial skills. They might have parts and other parts, but remember, managers are often a formal position. So let's look at some of the other things that are involved in being a leader, being a manager, and that includes critical thinking. So let's go to the next slide. So critical thinking includes the interpretation, the analysis of, the evaluation of, the inference, an explanation of data. We collect all this information to interpret it so that we can make better decisions. It's that collecting of the data, holding a wider view, allows us to see the bigger picture, versus somebody that's only focusing on one little piece or one little area of the unit doesn't know what other people are doing or other things that have been going on. So being a good critical thinker takes all that in. It's important to be able to see the big picture, and also it allows us to, a great term is thinking outside the box. I think that is being creative, taking this data, being conscious of the needs of the client as well as the organization you work in, as well as the staff that are working there. So it includes some creativity as well when you have critical thinking. Clinical reasoning is using the scenario that you're in, the clinical situation that you're in, and using the analysis to make a decision as far as patient care potentially. So collecting the data, it's like using the nursing process in a way. You're collecting the data, making sure that it's relevant, that it's useful, and using nursing knowledge, using the knowledge, our foundations, everything that you're establishing right now, to end up making the best decision. So clinical reasoning regarding the clinical scenario that you may be in. And clinical judgment is the decision that's made based on analysis of data, like what are we going to do? And it includes the patient's needs, takes, of course, into consideration. Because you may have a patient that says, you might come up with a fabulous idea, and the patient is not up for it. So we need to use the data, the evidence, our data collection that we have, kind of figure out what is it telling us, and use it to apply to the situation that we have on hand. Taking care of this person that has this disease process, and this is the data. So what do I need to do? Because we need to make sure that we have positive client outcomes. So using using our foundational knowledge, using the scenario that we're in, using the data that we have to make decisions, clinical judgment. So one of the probably harder things for people to do once we get out there in the world on the floor is prioritizing as well as time management skills. So some principles of time management are like discussing like who do you go to first? What are you going to take care of first? So that we, by prioritizing correctly, we are actually managing our time better because we're taking care of the more important things, allowing time on the other end for the things that could have waited. So if we fill our time up with things that could have waited, we're going to ignore and bad outcomes if we don't address things that needed to get addressed more promptly. So when we prioritize correctly, we see the patients that we need to get seen. It allows us to get the work done that needs to get done. So let's look at how we prioritize. Some principles that are listed here, but also on the fabulous prioritizing setting frameworks on Nurse Logic on ATI, includes systemic before local. So a good example in the book is life before limb. So prioritizing shock over a wound on the arm or something. So systemic versus before local. Acute before chronic. So acute, remember, sudden, less time before you would address somebody that has had this illness for a long time. For example, in the book, it talks about somebody that has a new illness or new onset of, say, chest pain or difficulty breathing before you would see somebody that has, I don't know, say diabetes. Actual problems versus potential problems. So I might see somebody that actually has a problem before I see somebody that we've determined is at risk for a problem. The other thing is listening to clients. What do they see as the priority? What do they think is the priority? Don't assume you know what the priority is or what they need to learn about or whatever. You listen to the client, include them, and don't assume. Another way we can prioritize is by recognizing trends. Which direction is this blood pressure going? Is it getting higher and higher? Is it lower and lower? Is it versus one episode of hypertension with no other episodes? So responding to trends versus just a single finding. Change in level of consciousness is an example that's given, recognizing that versus a transient finding. Recognizing signs of a medical emergency versus expected findings. So somebody that has a stroke that has increased intracranial pressure is going to present with certain signs versus the signs following a stroke. I'm going to go to the one that's showing the signs of increasing intracranial pressure. The last one on this slide is applying clinical knowledge to procedures. Perfect example listed here. And that's recognizing that the timing of administration of anti-diabetic and antimicrobial medications is more important than administering some other medications. For example, I'm going to make sure somebody gets their insulin before I make sure that somebody gets their Colase. I'm going to make sure that somebody gets their antibiotic before I, make sure that somebody gets their routine, say, aspirin. So clinical knowledge, I'm going to make sure I'm addressing my patients that are diabetic before I do the rest of my med pass. Timing matters in somebody that's diabetic, or somebody that has Parkinson's disease that I'm giving meds to, or somebody that is on antibiotics. Other priority setting frameworks include Maslow's. So if you remember Maslow, we're going to go for the bottom of base, the physiologic needs, before we can get to self-esteem. So I want to make sure that they have air and they're breathing and they have blood before I worry about socialization. I'm going to worry about safety before I worry about their, where they're living. So Maslow. The other hierarchy of the other priority setting framework includes the ABCs, so airway, breathing, circulation, we know. And then the D and the E is for disability and exposure. Good examples of disability and exposure and what that means on page 6 in the chapter 1. So for disability, it would be assessing for a evolving or current stroke, perhaps, because we want to address that to prevent furthering of the situation or development of disability. And exposure is talking about if you remove a patient's clothing to allow for an assessment or resuscitation, implementing heating or cooling depending upon temperature. You might put a heating blanket, or you might put a cooling blanket on depending upon what their temperature is. So what were they exposed to? Hypothermia, hypothermia. Another would be safety and risk reduction. So do we have, is there a risk for airway obstruction? That would be a big one. Give priority to the risks that that person is a particular risk to. Identify their risks and reduce them. So let's look at assessment and data collection. Think about the nursing process. So great example as well is get all your data. Before you make a decision, before you develop a plan, you want to have all your data. You want to have your assessment information. Another great example is before you call a physician for an order for something, make sure you have all the information you're going to need before you do that. Another framework includes survival potential. This is like in triage. If there is a mass casualty, for example, who has the likelihood of survival? Somebody that is extremely less likely to survive would be lowest priority. Another is least restrictive versus and least invasive. We're always looking for providing care to clients and using most least restrictive environment. So think about restraints. If somebody's identified to be high fall risk or self-harm, how can we manage this in a way and not use restraints unless of course we have to. Intervention should be least invasive. Example of you doing bladder training versus an indwelling catheter. Indwelling catheter, of course, is very invasive. Another way to think about setting priorities, which establishes who we see, when we see them, etc., is acute versus chronic, urgent versus non-urgent, and stable versus unstable. Somebody that's unstable will be seen before somebody that is stable. So those are really helpful tips. Let's look at some time management issues. With time management, Setting those priorities is going to help because we've identified who do we need to see first and what do we need to do. Some other things that we need to keep in mind is how we use our time. Like, are we conserving our time or are we wasting our time? Some really great examples, very common in nursing, on the bottom of page 7 on that chart, time management examples of time savers and time wasters. So documenting as soon as something happens, as soon as possible after something happens, is a time saver versus waiting to the end of shift to do everything. You'll be there at 3 o'clock in the morning if you work 3 to 11 if you do it that way. Another one is group activities that are for the same patient all at the same time, or those patients nearby, so you can so you're not walking back and forth. Gather up your supplies rather than going back and forth to central supply. So you're developing a vision of what you need before you go into the room. Also developing a plan. So taking a few minutes to plan for your day is extremely helpful. Know what it is you need to do for each patient. And remember that plans will change, most definitely will change. Call in others, use other people to help you out rather than saying, no, I got it, I could do it myself. That we could have reduced the amount of time used. Another big one that nurses don't do is avoid interruptions and graciously but assertively say no to unreasonable or poorly timed requests for help. I'd like to help you, but I just can't. Versus, oh, sure, I'll help you, and I'll put all my stuff that I've got on my list aside. I wish you had come to me a few minutes earlier, and I would have been happy to help you. Finishing one task before you start another one. That also can help. Using breaks to socialize with staff rather than socializing staff when you could have been providing care. So really good examples of time management strategies, both time savers and time wasters. One of the things that I believe we need to do as nurses is be respectful of ourselves, and that means to take time for yourself. Take the meals, your lunch breaks, your dinner breaks, your assigned breaks, as well as take time away from work. Go on vacation, take your personal time. You need to maybe, if you're on the unit, take a break and go for a walk if your patients are cared for. But you need to take care of self. Assigning, delegating, and supervising can be some challenging activities if you've never done it before. And so first of all, defining these terms. Assigning is when you give up the authority, the accountability, and responsibility to somebody else. So if you're making an assignment for different nurses, they're taking care of patient A, you're taking care of patient B. Delegating is transferring the authority and the responsibility, but not accountability, meaning it all comes down to you. Supervising includes directing and monitoring and evaluating others. So you'll see RNs will be responsible for supervision of both PNs and any assisted personnel. That's one example. And delegating and supervising is important for to make sure that quality care is being given to the clients. So let's break them down a little bit more. Assigning. In order to assign correctly, you need to have an understanding of the clients on the list. What's their acuity? What what are their needs, dressings, what precautions might they have, falls risk, maybe they're on neuro checks. How much time does it require to take care of somebody? How sick are they? That would be the acuity. And also when doing assigning, you need to take into consideration the staff. What is their knowledge? What are their skills? How much supervision will they need? Have they taken care of somebody like that before? What is the nurse-client ratio? Am I giving them one more client and they're being swamped? If you are given an unsafe assignment, you need to bring it to the attention of the scheduler. If the and the charge nurse to negotiate for a change. Sorry for the, oh my goodness, sorry for the typos there, but take the concern for the unsafe assignment up the chain of command if there's no resolution at the charge nurse level, and you may need to file a written protest, because if you're assigned somebody that you don't have the experience to take care of, that could be dangerous for both you and the client. So you need to advocate for yourself. Sometimes you need to come with a solution. I'll take that person so that so-and-so who's taking care of a person like this can have this patient. So you might need to come with a solution to the problem. Again, sorry for those typos there on the last slide. So delegating. So as a person that delegates, you need to be responsible for providing instructions, as well as assessing and evaluating the outcomes. So as a practical nurse, you can delegate to another practical nurse or assistive personnel. An RN shouldn't be delegating like the assessment part of the nursing process, that diagnosis part of the nursing process. As an LPN, you're assisting with that, reinforcing client education. And let's talk about some of the things that need to be done before delegating. So delegation, we need to keep in mind the predictability of the outcome, meaning is this a new treatment? Is this a routine treatment? What's the chance that there's going to be no problems going through? The predictability of the outcome. Potential for harm, is there a chance that something negative can happen, like risk or bleeding or risk for aspiration, and is the patient unsafe? This is considerations before we delegate. So the complexity of care, how complex are the tasks that are needed to be performed? Is the person we're delegating to legally able to perform that task? Is it within their scope of practice? We need to definitely be aware of that. And do they have the skills? Does it require nursing judgment? Does it require assessment? Is there need for, is there going to be interaction between the client and the delegee? Is there a need for education to be performed? Because these are going to determine who the task might be delegated to. On the top of page 9 has examples of things that can be delegated to a practical nurse and to a assistive personnel. So an RN can delegate to you to monitor findings. So input to the RN's ongoing assessment. You can be delegated to reinforce client teaching, to perform trach care and suctioning, to check NG tube patency, administer oral feedings, insert a urinary catheter, administer medications, IV. In the state of Pennsylvania, you're permitted to do IVs. Examples of things that can be delegated to assistive personnel, like a CNA or a tech, would be ADLs, bathing, grooming, dressing, toileting, ambulation, feeding with somebody without swallowing precautions, positioning or repositioning, these routine tasks, specimen collection, vital signs for a stable patient. So those things need to be taken into consideration for delegation. So we talked about the tasks. Let's talk about the considering who we're delegating to, and that includes, do they have the education, the experience, the background to have that task delegated to them? Do they have the knowledge and skill to perform the task according to the facility policy and procedure, or is that something that could be delegated to them? The delegate's culture, their background. They've demonstrated competence. They've done it before. They've been trained. They went through extra training. They've, passed whatever training. So those are important things to consider. So we talked about the task. We talked about the delegatee. And you'll often see these 5 rights of delegation. 1, the right task, the right circumstance, the right person, right direction and communication, and right supervision and evaluation. So the right task we talked about, scope of practice, is it something that requires little supervision, determining what task can be delegated to which delegatee. The right circumstance, more acuity would be a higher skill level of the healthcare member. And you also want to consider what their workload already is before you delegate something to them. The right person, do they have the competence? Is it in their scope of practice? Do they have the training to perform this task? Right direction and communication takes into consideration the information that's communicated with the person about what is it that they need to do, what kind of information are they collecting, who do they report something to, what are they reporting to, specific about the task and the person that the client that's being worked with. When do you expect results? And when do you expect follow-up? So if I'm the clinical instructor working with nursing students, I need to be very specific. You need to let me know vital signs by 9 o'clock. If you're unable to get vital signs by 9 o'clock, I need to know. If you have any vital sign that's outside of normal, you need to report that immediately. If I am speaking, wait until I'm freed in order to share this information. I remember early on when I was a clinical instructor, at the end of clinical, somebody tells me as we're reporting off to each other that their client had no urine output. So we were there from 7 o'clock in the morning till almost 3 o'clock in the afternoon, and they told me that their client did not have urine output at 3 o'clock. So that would definitely be a problem. So I, as the instructor, you as the person that's potentially delegating, need to give clear instructions on what's something that you want information on. If I tell you you're taking care of this patient, tell me that, make sure they're clean, warm, safe, and dry. You need to let me know if something is abnormal and the time frame for reporting that. So for supervision would be the responsibility of the person giving the delegation to follow up. Was it performed on time? Was it performed satisfactorily? Were not normal findings shared and reported and documented, etc. And evaluate. Does it need to? Does that assignment need to get changed at all? So very important that we understand the principles of delegation. A lot of questions on NCLEX include what can you delegate and to whom. So make sure you understand the 5 rights. Staff education, also known as staff development. And this is in bigger facilities, this is a separate department. Sometimes it's just one person. In bigger places, it's a handful of people that are responsible for the continuing education of staff, as well as orientation of new employees, both to the organization as well as to specific units. We'll see staff education. If there's a new piece of equipment, we'll do the training on how to use it accurately, or new syringe, or a new program that is being unveiled. They'll be involved in that. When you're oriented to a new unit, you'll often have what's called a preceptor, who you'll kind of assume their schedule so that you and they will work together. You'll have a checklist of things you need to do before you can be on your own or take increasing responsibility. But you'll have other people in your life when you get on the unit. You might have some people, probably the nurse manager or supervisor, that acts as a coach or a mentor. And preceptorship can last, in some places they have a year-long preceptorship, a residency kind of program. That's in a hospital, usually RNs. And other times you might have a preceptor that, is with you for the first 2 months, 3 months of your job. And then you'll have a mentor that you can reach out to and say, hey, I don't think I've ever done this before. Can we go over this? One of the other things that we have to get used to on a unit is the unit itself. What's the culture of the unit? Believe it or not, units can have different cultures. What are the roles of the different people that work there? Who's in charge? Who do you go to? Who's the unit clerk? How does this work on this unit? The next slide talks about Patricia Benner, who is a nurse theorist, and she had some really interesting ideas about nursing ability. So let's go there. So Patricia Benner essentially highlighted and recognized that a nurse isn't an expert upon graduation, and there are stages that we go through in order to build our competency and become an expert. So as a nursing student, or a first-year nurse even, you're a novice. You may be exposed only just to minimal clinical experiences, and more concrete in your thinking, versus an advanced beginner that you're starting to use your experiences that you had to then use them for future practice experiences, all the way up to the expert. This is somebody that has lots of experiences, a wealth of knowledge, so that they can look at scenarios and clinical patient situations that are different. They have a different analytical ability. This happens after years of experience and education and exposure. So there are stages of nursing ability, novice to expert. Some people ask, like, how long does it take before you really feel comfortable? And if you look at competent nurse on page 11, these are usually nurses who have been in practice for 2 to 3 years. They demonstrate increasing levels of skill and proficiency in clinical judgment. They exhibit the ability to organize and plan care using abstract and analytical thinking. And they can anticipate the long-term outcomes of personal actions. So you may, in a year or so, feel a little bit more comfortable, and you know where things are, and you can anticipate needs. But you really start working smoothly probably in 2 to 3 years. But again, not as an expert until many years later. So there's an interesting article that she wrote, or her theory about novice to expert, that's sourced or cited at the bottom of the page. If you have a minute, you can do that. But it is a very, very often cited um, theory. And even when you think of in nursing school that in semester one, the questions might be a little bit, um, let's not say easier, but more knowledge based, recall based versus application based. And as you're ending semester one, going on into semester two and three, you'll see that the questions will be a little bit more detailed, require more thinking, critical thinking. So even in nursing school, we use her theory of novice to expert. One other thing that falls under leadership and management is quality improvement, because it's how we continue to make improvements in the care that we provide. It's by looking at and acknowledging that there's issues, and it's the steps that are taken to resolve those deficiencies. And oftentimes we'll set standards. This is our goal. And then we'll collect data using auditing or something to see where we stand. JACO, the accrediting body, requires that we use QI and quality improvement. You'll see performance improvement. You'll see other terms used for that. But essentially, we're looking at what are our policy and procedures? What processes do we have in place? Quality improvement teams are usually interdisciplinary. Laundry, housekeeping, nursing, dietary, administration, everybody's on the team. And QI is everybody's responsibility. Conflict resolution, we talked a little bit about that in a previous class about communication, but when we're talking about conflict, we're talking about when there is opposing ideas, there's opposing feelings, there's opposing behaviors, opinions between individuals. If you're a human, it's inevitable to have conflict, but we need to know how to deal with it. Some of the causes, contributing factors include poor communication skills, unclear expectations, or unclear or undefined roles, when there's conflict of interest, incompatibility between individuals, it just is, when staffing changes, when managers change, you could have conflict, and diversity related to age. You have a nurse that's been on the floor 40 years, and then you have somebody that just graduated, walked across the stage. Genders, male, female, race, ethnicity can all contribute to conflict resolution. So some categories of conflict would be within the person, I'm conflicted, or interpersonal, between others, bullying, incivility, believe it or not, can be a problem in nursing. Lateral incivility between colleagues on the same level. And sometimes you'll even see intergroup, dining versus nursing, housekeeping versus nursing, maintenance versus nursing. Maintenance, they keep banging walls and, putting holes in the wall. So you'll see interpersonal, and intergroup conflict. So resolution includes keeping communication open. If you see things starting to get worse, making attempts to de-escalate, using assertive communication, using I statements, focusing on the problem, not a person. So you're not saying you. Listen, really listening to what people are saying. If this conversation is getting intense, then move it to a private location, or say, you know what, we need a break and we'll come back when we're in control. And ground rules for any kind of conflict resolutions, whether it's two people or more, would be that one person speaks at a time, and everybody gets a chance to speak, and they're treated with respect. So steps of problem solving include identifying what the problem is, discussing potential solutions. How are we going to fix this? Analyzing, selecting, agreeing upon a solution, implementing it, and saying, did it work? Did our attempt at fixing this problem work? Looks like the nursing process to me. Negotiation is a process that helps people that are in conflict or parties that are in conflict. Generally, when you're negotiating, when you get to the point where you're negotiating, you're trying to come up with an agreement. And you've probably all heard of win-win, that both sides win, get something, get what they want. And sometimes that's not possible. Somebody needs to give up something. So if you can get a win-win, that's great. But sometimes you get a win-lose, win-lose. I lost and I won, you lost and you won. And both parties agree to give up something. And it has to be agreed upon, because you can't say yes and then change your mind later. You can't say, well, I still want my way. So this is an agreement that's made between parties. Assertive communication, we talked about, is communication that is honest and direct and non-threatening. We talked about it in ISPAR when we're communicating, a report. Strategies for assertive communication would be maintaining eye contact, establishing trust, making sure that you're in the right place. You're not doing this in the hallway or at the nurse's station necessarily. You might, go into a quiet room. Certainly not doing it in a open corridor. So establishing trust, using I statements, avoiding you statements, and state concerns. I feel, convey empathy, and focus on the behavior, avoiding any personal attacks. Handling grievances. If you have a concern, whether it be about staffing or something that happened on the unit, you want to use the proper chain of command. We talked about you don't want to go over somebody's head. If it's not resolved at that level, then yes, you go to the next step up. It may require something more formal. If it's not resolved at that area, then it might require professional mediation. But take it back to, this is like an employment, but take it back to school. If you have a problem with my class, you talk to me. That doesn't work. You go to Dr. G. That doesn't work, etc. So handling grievances, handling it properly is a skill. Sometimes we get very emotional, so we want to make sure that we are handling ourselves as well as following protocol, which would be chain of command. Resource management is using our people, our money, and our stuff appropriately. And all nurses have responsibility at resource management. And we want to make sure that we're using our information, using our resources frugally. We don't staff where we don't need to staff. We don't use supplies that we end up wasting. So there are great examples on page 18 in chapter 1 that talks about cost-effective care. So take a minute to take a look at some of them. And the last couple slides is about the LPN as the last slides are about LPN as a charge nurse. So it depends on the State Practice Act, but you'll often find LPNs in long-term care acting as charge nurses. So it requires that the facility that does have LPNs as charge have policies and procedures, and that's general operating protocol. So how does an LPN function as a charge nurse? Let's look. So for an LPN to act as a charge nurse, they should be prepared to do that. And that means that they have training or experiences or education beyond general LPN school. It may be on-the-job training that prepares them to perform this charge nurse perform a job as a charge nurse. Because as charge nurse, there's assigning, there's assessing of patients, there's delegating of tasks, there's shift reports, and handling workplace issues like supervisory issues, disciplinary issues. that an LPN may come across as a charge nurse. So yes, LPNs can be charge nurses, but should have the experiences to function in that capacity. So the last slide here, this last slide here is something from former President John F. Kennedy, that leadership and learning are indispensable to each other, that we're always growing, we're always learning, we're always becoming better people. So on that note, this is the end of the podcast. Thank you for listening.